downward rotation. Okay? So if we already know that, then I'm not really going to use P&F to, well, we will use still, right? So patient comes in and the patient's scapula is downwardly rotated, okay? So if we remember the two diagonal patterns we had for the scapula were posterior elevation, anterior what? Depression. Okay, so that was the first diagonal. Okay? And that diagonal fits with what? That's the D2 diagonal of the upper limb. Okay? So, right? That's posterior elevation, anterior depression. So, when I do the D2, right? This is D2. This is going to be anterior depression, posterior elevation. Okay? D1 is going to be anterior elevation, posterior depression. Okay? So, we have a D, this is D2, and then I'll show you the D1. I'll tell you the truth, I don't really go, I know the patterns. I don't call it by the Ds. I just call it by the anterior, posterior. It just makes more sense to me. But anyway, so what you want to do is you want to assess. We know the patient's scapula is downwardly rotated. So the first thing you want to do is assess how does that scapula move in the first diagonal. Posterior depression, anterior depression. Does it go all the way? Is it tight? Is it loose? Is it tight going down or loose coming up? Now, if we know it's downwardly rotated, then we know that it's kind of stuck down this way, and going up could be very easy. Could be no problem. So you just want to assess what is the passive nature of the what? The scapula. And if you want to, the best thing to do is to then compare involved to non-involved, because you use the non-involved as the baseline for what should be normal. So a lot of times, what I'll do after I do symmetry eval is I'll do what I call a feel eval. I'll just put them on their sideline, feel what the scapula is doing, and then I'm going to check the other direction. I'm not going to check the other side on her because we know that there's really not a difference. So this would be anterior what? Elevation, posterior depression. So this is our D1 diagonal. And I'm just seeing how she moves. Is it smooth here? I'm just doing passive what? Passive range. So I always do passive range first. And now I want to see how does the patient actively move in the diagonal pattern, okay? So what I want you to do now, relax, okay? So what I probably would do, I'm just trying to slow down the thinking process. So what I would just probably do is, I'm going to just do passive, just relax, and I'm just going to feel how that feels like. Okay, Kristen, I want you to move with me. I want you to move with me here. Great. So I'm just feeling how she moves in the what? How does that active range move in the diagonal? Okay. Now I may want to give resistance in that diagonal just to see how that feels. Okay. Push down. Good. And up, 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 down. Good. And that feels very good to me. So there's no problem with the range of motion in that diagonal. There's no problem with there's no problem in the range. There's no problem with the strength in that diagonal. Feels pretty good. So now I'm going to check the other diagonal, the other direction. Okay, just relax, and I'm going to move you in this direction here. And the one reason to do passive is to get a feel for how much range is there. Another reason to do passive is to teach her this is the direction. Okay, do you feel this motion here?
Yes.
Good. I want you to move just like we were doing. Okay, so move with us, with me. So now I get a feel she's doing it, no problem. So now I'm going to give her some resistance, push, push. Good. Up, 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 up. Good. Down, down, down. Up, up, up. She actually is a little weak coming this way. Okay? Did you feel that?
Yeah.
So she's a little weak in this direction. Now, if she were like a shoulder biomechanical patient, then maybe I would treat that direction to make it stronger. Okay? But we're talking about CVA, so I'm going to come on this side, and most commonly, if the scapular is downwardly rotated, we want to work what? Posterior elevation, right? We want to work on that. So what I would do with the same technique with the CVA patient, and if you look at the technique, I'm going to do rhythmic initiation. Do you see that there? And the first thing I'm going to do is do passive range with the patient. Okay? And then I'll have the patient move with me. Great. And now what I probably will do is I'm going to work on, because she's downwardly rotated, I'm going to work on the posterior elevation in terms of, well, it depends. A lot of patients can do it on their own, and they kind of do this, meaning their scapula's all over the place. Okay? Some of them have trouble. They can come up into that direction, but they don't go all the way because they don't have the strength. So there's a variety of things we can do to treat the patient. I can use concentric contraction to go through full range. For stability, I can use eccentric, or for strengthening, I can use, for stability, I use isometric. For strengthening, I use eccentric. It also depends on the patient's cognitive ability. Do they understand what we're doing? Some of the times, doing eccentric on a stroke patient, they just don't have the control, or they just can't follow the directions well enough.